PMDC and the Prime Minister Task Force for the Management of Hepatitis. Next. आजकल हम बात कर रहे हैं WHO से elimination of viral hepatitis from the globe, and it was 2018, 2016 जब हमने ये बात सोचना शुरू किया कि we will be able to eliminate viral hepatitis from the globe, and WHO ने इस सिलसिले में कुछ committees कायम की. This was the first solid thing which came out from WHO. That was the guidelines for the simplified guidelines for the management of chronic hepatitis C. And it was an honor for Pakistan that Professor Saeed was the chair of this committee who made these guidelines for the management of hepatitis C on the platform of WHO. Next. And recently, we had these guidelines from chronic hepatitis B published last year. And again, it was a proud moment for Pakistan when Professor Saeed was again chairing this committee who made these guidelines for the management of chronic hepatitis B. So I can simply say that he is the most appropriate person in the whole world to talk about chronic hepatitis B and its management today. Professor Saeed Hamid, sir.
Thank you, Shahid, for the kind introduction, and thank you for the invitation. अच्छा ये बताएं कि कितने लोग इस ऑडियंस में OBGYN वाले हैं? Can you please raise your hands? So a very good number. चलें, आपसे फिर बातचीत ठीक रहेगी. So Can I ask you, जिन्होंने हाथ उठाए थे, उनसे मैं 2-3 सवाल पूछ सकता हूँ, और if possible, how many of you use hepatitis B immunoglobulin at the time of childbirth? इतने सारे लोग, my goodness, 10-12 people, right? How many of you use or ensure that the birth dose vaccination of hepatitis B is given to the newborn? ज़्यादा हाथ उठे हैं सब. Excellent. How many of you are testing every woman for hepatitis B and, sorry, I should say pregnant woman for hepatitis B and hepatitis C? A good number. Chale, okay. Right, so my task is to present to you in general the simplified guidelines for hepatitis B and hepatitis C, which have been done on the platform of WHO, right? And then we can discuss के guidelines का हमारी practice में क्या role है, and what do you think that we have done correctly or not correctly. I have nothing to disclose. Acha, everybody knows these statistics, I think. Hepatitis B is around 300 million people around the globe at the current moment. So one of the largest chronic infection burden, disease burden in the world. Pakistan has a prevalence of 2%, which means 4.2 million people are infected. This is less than hepatitis C, but is still quite a big number. Achha, issue ye hai ki despite the fact that this is such a large infection, very few people have been tested. It is around 19% have been tested, and only 2% have been treated out of the 296 million people. And therefore, we are lagging significantly behind the screening, diagnosis, and treatment of these patients. And therefore, there was a need for simplified guidelines for hepatitis B, which the WHO took a step towards. और भी बहुत सारी हर सोसाइटी की गाइडलाइंस आ रही हैं, कुछ दिन में, कुछ महीनों में ईज़ल की भी आ जाएगी, यूरोपियन एसोसिएशन की और अमेरिकन एसोसिएशन की और दूसरी एसोसिएशंस की, एंड लेट्स सी व्हाट दे से, बट आई विल प्रेजेंट व्हाट वी ऑलरेडी हैव नाउ. Okay, so why the need for revising these guidelines? There is hepatitis B guidance is perceived as very complex. Many physicians, many specialists do not understand the complexity of the testing that they have to do, or they have had to do. So you need age, HPV DNA, ALT, you need an HPV threshold, which is more than 2,000 or 20,000 in some guidelines. So it varies from guideline to guideline. The existing guidelines lack, and now, of course, we are talking about the global scenario, so many of these guidelines lack data from, for example, let's say sub-Saharan Africa, where there's a very high prevalence of this infection. And there is increasing evidence of ongoing integration of hepatitis B infection and oncogenicity, yani cancer development of hepatitis B. And this occurs as time goes on, and as the longer a patient lives without the treatment, the integration of hepatitis B genome into the human genome continues to occur. We used to think that it was only a phenomenon which would happen early in life, but this continues to happen until a lot of people get this integration, which is then extremely difficult to remove or cure, for example. There is ongoing horizontal and vertical transmission, of course. HPV cure is really not possible at the moment because we do not have the right drugs to do that, and therefore it remains an incurable infection right now. It is a treatable infection, it is a controllable infection, but it is not a curable infection. So these are some of the guidelines that are already out there, and as you can see, there are different parameters for different guidelines. For example, the ESL is more than 20,000 HPV DNA. APASL is more than 20,000 HPV DNA, and this is the WHO, and APASL is also more than 20,000. इनमें इन guidelines में सबसे एक चीज़ जो मुतफ़क्का है वो ये है कि the HPV DNA levels need to be done, and of course that is the most expensive test that you need to do, and also that is the most inaccessible test that you need to do because patients do not have money and the government programs do not have the capacity to do all these HPV DNA levels, which is a shame, but that is the reality of life. So therefore, there were many people who would come under the heading of who not to treat. So the who not to treat list was much longer as compared to who to treat. And therefore, immediately, there are a very few number of patients that were going into treatment, and the others were denied treatment because they did not fulfill certain criteria. So the guidelines committee was set up in 22. We worked all the way through to 23, and we released these guidelines in March of last year, 2024. And so these are new. I don't know whether people have seen this or not, but I will take you through them. So what is different with the WHO guidelines? The WHO guidelines are directed towards low and middle income countries. That is important to remember. They are more concentrated on epidemic settings or endemic settings in some cases. They are directed towards the program managers. This is a public health approach and not an individualized treatment approach, which is relevant for the high income countries where all the other guidelines come from. And so therefore, one has to remember that this is a very much a public health approach, and we need to see it in that scenario. Just a couple of slides about how the WHO guidelines are made. This is what is called a PICO or the grade system, and the grade system consists of this first element, which is the PICO. What does PICO stand for? So you need the population that you are trying to make the guideline for, you need the intervention, you need the comparator, and you need the main outcomes. And on top of that, which is most important, is that you need acceptability, feasibility, values, and preferences. All of these items related to the patients and the communities and their families and so on. So what is acceptable for patients, what is feasible for patients, what is feasible for the society, all these things are very important as the hard evidence that the background contains. Of course, resource use, cost effectiveness, and so on. So I think these are relevant to say because then these guidelines become fairly simple for us to adopt in low middle income countries. The guidelines are said to be strong or conditional. If the evidence is good, they are generally considered strong, but even if the evidence is not that great, and there are acceptability and feasibility values, you can still have a strong recommendation with low quality or low level of evidence. This is acceptable, right? Which is whereas it may not be acceptable in other guidelines. And there's a lot of background work that is done. So for example, at least 15 systematic reviews that are done as background information, modeling where reviews are not available, landscaping and access and costs, acceptability and values that I've already mentioned. So a lot of this material goes into the development of these guidelines. So here are some of altogether there were 29 recommendations, of which 4 are new, but we don't want to go through the whole 29. We will just focus on a few of them, and I'll talk about the who to treat, the first line treatment. In particular, we'll spend some time on the prophylaxis of mother to child transmission, I think, which is most important for this group, and then simplifying diagnosis and service delivery. Okay, so the first thing is who to treat, and this may not be immediately relevant for the obstetricians in the room, but certainly for general practitioners and so on, and even for the specialists, this is what we are recommending. So in the four recommendations which are related to whom to treat, there is only one recommendation which depends on a HBV DNA level, and that is recommendation number 2. And therefore, anybody who has an HBV DNA level of more than 2000 and an ALT above the upper limit of normal is eligible for treatment, no matter what else, no matter what other factors and so on. So there's only one recommendation that is dependent, and therefore we take out the inaccessibility, the cost of the HBV quantitative DNA, and make it simpler for people to get on treatment. The other 3 recommendations do not contain any knowledge of any or requirement of quantitative HBV DNA. So the first one is if there is significant fibrosis, and that significant fibrosis is measured by a simple APRI score. And I'm not sure whether you will understand APRI score or no APRI score, but it is just a measurement, a non-invasive measurement of liver fibrosis, which depends on a platelet count and an AST level, and a computer will give you a number. So anything APRI score of more than 0.5, which translates into significant fibrosis, which in our terminology we call F2 fibrosis, such a person is eligible for treatment despite the fact that they've not had an HBV DNA done or any other thing done. The next one is if there are co-infections that are present, or there's a family history of liver cancer, or there is an immune suppression, comorbidities, etc., etc. These people will also be eligible for treatment irrespective of any other factors. And finally, in the absence of an access to an HBV DNA, persistently elevated ALT levels are also an eligibility for treatment, although this may be sometimes debatable because there are many causes of elevated ALT levels, as we've heard in one of the talks in the morning. So here is some of the evidence that we can take you through. So we talked about a 2000 level of HBV DNA. And if you see, these are outcomes of liver-related problems. So liver-related deaths, liver cancer, liver cirrhosis. So if you do a single HBV DNA less than 2000, there's nothing much happening here. But then the bar starts to rise when you go beyond 2000, clearly, to liver-related deaths, in liver cancer, and even liver cirrhosis. Similarly, there's a good correlation with the abnormal ALT level. So we believe that the HBV DNA of more than 2 is more than 2000 is a reasonable parameter which can be used. This is just if you just concentrate on the lower end of this, these are numbers that you have numbers needed to treat. So for example, if you are in the 2,000 or 20,000 range, you only need to treat 59 patients to prevent one liver cancer. And you need to treat only 21 patients to prevent 137 liver cirrhosis. So it becomes cost effective and cost efficient if the level is at 2,000. So what has happened, or what can happen with these guidelines is that immediately the number of people that were denied treatment increases. So here is the 2015 guideline, just at a look. This is the only parameter which goes through for treatment, which is liver cirrhosis and elevated DNA. Here, everybody makes a stop, and you need to defer treatment, and you need to re-examine them, retest them, etc., etc. On the other hand, even visually, you can see that almost all categories go through for treatment, become eligible for treatment, other than this last category, which is persistently normal ALT and a very low level of HBV DNA. So this translates into a lot of treatments that can be done. So the recommendation for treatment is TDF or entecavir, and even now the new one, the TAF, can also be used. So that's not a big issue. So here is the important parameter that I want to talk to you about mostly, and this is what is the in preventing the mother-to-child transmission of hepatitis B using antiviral prophylaxis. So we have three, as we talked about just now a little while ago, we have three parameters, or we have three interventions. One is the drug prophylaxis, where we reduce the HBV DNA levels down. The other is the birth dose vaccination. And the third is the hepatitis B immunoglobulin that many people raise their hands for, right? So what we are suggesting is, in settings where HBV DNA or E antigen testing is available, you do a test, and if it's more than 200,000, you start that pregnant woman on treatment immediately, right? For the new recommendation is, in settings where neither HBV DNA nor E antigen testing is available, prophylaxis with TDF with tenofovir for all hepatitis B positive pregnant women may be considered. This is a conditional recommendation with low evidence for certainty, but certainly it is a recommendation, right? So you do not need, you simply need a hepatitis B surface antigen positive, which many of you or all of you test as you raise your hands, and this becomes an eligibility for treatment. The other important consideration, and this is a preference, this is not a recommendation, but this is a preference. The recommendation has been so far to start treatment in the third trimester, 28 weeks onwards. But it is preferable to start treatment from the second trimester of pregnancy and until at least delivery or completion of the infant hepatitis B vaccination series, which means the 3 injections that they give in the EPI program, right? So until then, at least until then, the tenofovir needs to continue. And in fact, there is now data to suggest that you can start treatment at any trimester. These drugs are safe. And even now, there is data for the new drug, which is the TAF, the tenofovir alfenamide, and there is a lot of data for TDF, for tenofovir dipivoxil, which is the older version, for safety. Starting early gives you 2 things. One, that you're starting at a time when there's enough time for the suppression to go down, for the viral levels to go down, and therefore even very high viral levels will go down if you start early. If you start in the third trimester, which is 28 weeks, the very high levels, and these levels, as you know, can run into the millions and billions, these levels will not go down to 0 levels or non-transmissible levels. And therefore, prophylaxis is an extremely important recommendation, the medical prophylaxis, is an extremely important recommendation for the prevention of mother-to-child transmission. Of course, this does not take away from the fact that all interventions should be given, the timely birth dose, this does not take away from the fact that timely birth dose has to be given. And we know what timely birth dose is, within 24 hours. And I was so glad to see so many hands raised up that you people in your units are giving timely birth doses. That is the only sure shot way of reducing or affecting the epidemiology, reducing the incidence and the prevalence of hepatitis B infection more than anything else that you can do. So please continue that if that is what you are really doing, and if the drug is available. So the implementation considerations are that increased coverage of hepatitis B birth dose vaccination should be the priority, right? Why are we focusing so much on the drug prophylaxis? Is the fact that in some cases there still may be transmission if the levels, HPV DNA levels, are not very well suppressed. This still could be a transmission despite the birth dose vaccination. So we want the prophylaxis in addition to the birth dose vaccination.